Until I looked at myself in the mirror one day and I was disgusted with what I saw. So I said, you got to make a change, man.
It's all about fun, laugh, and get through life. That's what it is.
I find you have everything to gain with Christ, and without him, everything to lose.
Said I'm gonna lay you down, just like a bridge over troubled water.
Hello, and welcome to Keeping It Real with Shannon. As you know, this month is Cancer Awareness Month, and our topic tonight is Cancer Awareness, Just Get Me Through This. So we want to welcome you to the show tonight.
Thank you. So what I'll show, listen, today, this month, all of October, is a lot of information out there that's needed for breast cancer. And we have a wonderful show tonight. And with our guest today, let me introduce Dr. Donna Marie Manasat. Now, Dr. Marie Manasat is the chief of the Division of Breast Surgery and director of Maimonides Breast Center program in Brooklyn, New York. Prior to joining the Maimonides team, she was co-director of the Women's Breast Cancer at Stanford Hospital and chief of breast surgery. Under her leadership, the Women's Breast Center at Stanford Hospital became the first center to be accredited by the American College of Surgeons National Accreditation Program for breast centers. Welcome. I'd also like to welcome Dr. Brian Hall. Now, Dr. Brian Hall is certified by the American Board of Surgery. He is also a fellow of the American College of Surgeons. He joined the surgical faculty at SUNY Stony Brook as an assistant professor of surgery, specializing in trauma, critical care. He joined Brooklyn. He returned to Brooklyn to join the Advantage Care Physicians as a surgical attendant. He became director of the surgical intensive care unit at Wyckoff Heights Medical Center. He remains with ACPHN, which is the it's the Advantage Care Physicians and Wyckoff Heights Medical Center until 2017, at which time he formed Brooklyn Surgical PLLC. And our final guest, our special guest, I'm personally a breast cancer survivor, but our guest, Ms. Dorothy Barnes, is a 5-time cancer survivor, and she's here to tell us her journey.
So thank you all for taking part of the show tonight, Dr. Manasat, Dr. Hall, and Ms. Dorothy. This is a very serious topic, and I know when people are diagnosed and they hear that word cancer, I can't even imagine, what you think about at that time and you're going through it. Miss Dorothy, now you said that you was a 5-time cancer survivor. At what age were you first diagnosed with cancer?
In the year of 1965.
And you was how old at that time?
26.
26. Oh, that was young. And so, as during you have been diagnosed 5 times. So you had breast cancer, and what else was you diagnosed with?
I had ovarian cancer, throat cancer. I had throat cancer twice, breast cancer twice, ovarian cancer once.
So now, being diagnosed 5 times, I can just imagine what you was going through. How did you make it through all of this? I mean, what support did you have? What did you go through?
I guess it was just my faith. I put my faith over fear.
And Dr. Vanessa, what was like when you first heard the news?
Well, I'm an advocate of being in the hospital, not the hospital, getting checked every year annually for the mammograms. But when I was first diagnosed, you have this inner sensation, like everything just drops. It's like it's really hard to explain, but it my inner chest would just drop and hit the floor. And I had to think about everything around me, everything's going on, my family, friends, just my whole life at that point. But then I had to get myself together and say, you know what? You can do this. I got to stand fast. I got to move forward. I got to stay focused. And that's when I first met Dr. Hall, when I was first diagnosed. And, he was giving me the opportunities and different measurements and giving me the choices of what I can do and what can happen. And at the time I was stage 0. And he said, okay, I didn't have to make a decision right away, but also the same time the following year, since I was diagnosed in 2016, may not have the same results. So since I already been in the healthcare and I had already made a decision to have the mastectomy and to move forward with that.
Now, Dr. Manistat and Dr. Hoare, either one you can speak first. It doesn't matter. When someone comes to your office, when the women come to your office, and we're gonna say men too, because we don't talk about men having being diagnosed with breast cancer. Like, what is the first thing once they tell them that they have cancer? What is you normally do? I know you sit down, you have a little talk with them and everything, but to keep, I know they're in shock, because I know how it was with me when I thought I was. I mean, they was ready to put me in the hospital at the time because I couldn't take it. But when they come, how do you assist them at the beginning? Like when you talk to them about what journey they're going to be on a journey. So whether they should take chemo, radiation, how do you speak to them? How do you talk to them about what they should do?
Well, if I can go first, generally, I kind of meet them where they are. I think education is a key component of this. I think that patients need to understand and be a part of the decision. I generally draw pictures because I think it's easier to understand. But I think I give them bits and pieces of information, feed it to them the way they can most receive it.
Mm-hmm. Dr. Hall?
Absolutely, I agree. I'm a firm believer in I'm very visual. So I have my diary and my pictures go with patients. I always try to stress with them. Breast cancer is one of those things where, again, there's no cure per se. But, with early detection, a lot of times, a lot of patients I see, they're early stage. So when people hear the word cancer, they think, oh my gosh, the worst. But, stage 0 and stage 1 cancer is not the same thing as stage 3, stage 4. So I try to force that and try to, let them understand there's a big difference in what they have going on with them. I also try to incorporate family as much as I can. Before any patient comes in, I always, have my staff reach out and have them come with family, because what I realize a lot of times, especially when they hear their diagnosis for the first time, they go home, the family will ask all these questions, they're gonna get so worried, so concerned, it's gonna make it flustered, make it even worse for them. So I really try to calm them down, have family there, go over all the questions with them, and try to really emphasize or really structure, tell them that you have to think very positive with this right now, with the diagnosis.
I agree. That's absolutely correct. I agree with that. And also that a lot of people who have, any type of sedentary lifestyle or cancer, any other type of other comorbidities, they need to focus really on diet, changing their diets and see what role the diet plays, how it contributes to the condition.
So now when you talk about diet, because I know someone who had breast cancer or has breast cancer or whatever, and they changed the diet. But even though you might change your diet and everything, you still would have to take the treatments, chemo and radiation, or can you not take chemo and radiation? Can you just take the pill, even though you may do? Sometimes I understand that they do the surgery and then they don't take the chemo and radiation, and then sometimes they do all three, and then they say they have to take a pill. So I know each person is an individual, so it depends on how far they are and how off. Do you have to take all three, or can you not? You can say I don't want no radiation, I don't want no chemo.
So the breadth of options speaks how far we've come in breast cancer management. It really depends on the type of tumor we're talking about. The earlier stages often just require surgery and or radiation and maybe a pill. And then the more aggressive tumors may require more aggressive treatment with chemotherapy and other types of drugs. I think the best way to look at it is that when we take these tumors out or we biopsy them, we look for specific features that we feel we have tools for. And surgery as it stands now is most of our patients get surgery to start. Some patients get medicine to start. Again, we're trying to tailor to what the patient needs are and what the cancer actually needs to fight it. So it's not really a choice per se in terms of can I take radiation or not. Often if we're recommending it, it's because it's the best option. But there are some choices within different types of surgery and some choices in different types of drug regimens. But overall, the treatment regimen had been designed to address the particular tumor. Nutrition is very important. I think I look at it more as a support rather than to supplant or replace what recommendations we're giving. You still need to do good nutrition, even if we're doing these medications and treatments, and continue after treatment as well.
Mm-hmm. So, Miss Dorothy, now each time that you was diagnosed, did you do radiation and chemo or just surgery? What did you choose?
Surgery. No chemo, no radiation, and no pills.
Okay.
You know, back in 1965, we didn't have the research available then that we have now, so I couldn't research it. So I just told the doctor, they did the surgery and that was it.
Mm-hmm. Mm-hmm. So you didn't have any chemo or radiation or the pill? And
no radiation or chemo at no time.
Mm-hmm.
You know, when we look at the time that Miss Bonds, the Dorothy had her breast cancer diagnosed back in 1965, it's a long time, and we have evolved with technology since then. But the interesting thing that goes on today regarding health disparities, that is always that pivotal question of why is it that there's more white women that are diagnosed with breast cancer, but more Black women die from it?
So I think that it's best to look at this in terms of a number of different factors, some of which include how people succumb to the disease. Some of it happens to be as a result of patients presenting with late stages, and within the African-American community and Afro-Caribbean community, this can be a result of just access to healthcare, as well as just education about the disease and different types of treatments that are available. But some of the reasons that people succumb to the cancer is because of the actual biology of the cancer itself, meaning that just the features of the tumor are very aggressive. And we found in some of the literature that in African cultures, African-American, Afro-Caribbean, that there may be some aggressive forms of these types of cancers, even if you're somebody who does your treatment, your screening regularly and goes to the doctor right away. It's why I'm actually particularly emphasized to the African community that it's really, really important to do screening, because these can be very aggressive tumors, and the earlier you find it is your best defense.
Dr. Hall?
I'd have to agree. I think what you were saying earlier, I think the Caucasian, the white population, they tend to have more screening or more access to healthcare. And a lot of times, in our community, we don't have the same access. As a result, a lot of patients will come. I've seen quite a few patients come to my doorstep with already stage 4. I mean, literally, you can see the cancer. You can smell the cancer, I should say, as they come through these doors. And it just comes down to access to healthcare. So I think that's the disparity that you'll see between the two populations.
And another thing I wanted to add to that, we know they have the routine screening. What is it now? At age 40? Age 40 or 35. But what I never hear is that for those patients that come in that have first generations, that they is really outside that screening process, where they should be screened 10 years younger than when mom, that first generation, was diagnosed. And I remember having a patient when I worked in the ER, and she was just there running through fast track for something minor. And when I did that assessment, and I told it to her, her mom was diagnosed at 35, and I told her, you need to be tested at 25. And it was the first time she ever heard that. So why, when they put the routine screen up there, they don't give that option publicly?
Okay, we're gonna hold that question, and when we come back, you answer that question when we come back. So we're gonna take a quick break, and we'll be right back.
Why aren't you voting?
When you vote, you can do something about everything. At voteforyourlife.com, it's never been faster or easier to make a plan to vote.
Time is running out, but you still have the chance to use your power.
Check your registration and make sure your address on file is correct.
Find your state's deadlines, learn about local candidates, and request a ballot.
You'll be able to see where candidates stand on issues you care about.
Order a ballot request form to be mailed to you with prepaid postage,
allowing you to vote early, easily, and safely.
Make a plan to vote early by finding your nearest ballot drop-offs, in-person polling place, or local mailbox.
And this is where you rise, this is where you shine, this is where you become the greatest of all time. History in the making.
Vote for your life.
We're back with our special guest today, Ms. Dorothy Barnes, Dr. Hall, and Dr. Vanessa. Now, before we went to break, Dr. Vanessa had asked a question that we can answer now. If they didn't forget the question.
Anyone can jump in.
Yeah, so the question essentially relates to just the information I think that's communicated to the Afro-American, Afro-Caribbean cultures about general screening. And I think as just a general rule, there's a lot of information out there about screening. The specifics when it comes to genetics, I think not just in that culture, but in all cultures, we don't advertise as much in the media. It's a conversation that we often have with our healthcare professionals, and that's where it comes down to, again, access to care. If you have individuals who don't really have the access to care that they need, they're not seeing a physician, they're not getting regular checks, they're not going to have the conversation that, hey, you have a family history, and it's probably a good idea that you get your screening done a little bit earlier. Often if they have entered the screening realm, part of their report will generate information about their risk. There are genetic counselors that are available. The popular version is what you see on television called 23andMe. There's some others that are out there as well. Mm-hmm. And although these are not replacements for a true genetic counselor, it does start to raise the issue or present the information to the community that there's genetics out there. You should be looking at your genetics because it does impact your health.
Mm-hmm. Now, we always say that when these things happen, we don't have the care, we don't have the necessary facilities that we need. But do we encourage women and men both that, even if it's not in your neighborhood, that you go to another neighborhood to see a doctor or get the care that you need, because these are things that happen, or this may be something that's in your family that you want to keep yourself checked, say like, high blood pressure, diabetes, all of these kind of things are in your family. So, you have to keep those things checked. So if it's not in my community, if I don't have the facility in my community, I would go somewhere else, to have myself checked or diagnosed or whatever. Dr. Hall.
I think now, especially in Brooklyn, really in the New York area, the facilities are there. Dr. Mann said, at Maimonides is a world-class institution. The facilities are in Brooklyn. You can go across the bridge to NYU, Columbia, Cornell. So not having facilities is not really something that's not a problem for us per se. Even if you go to a local neighborhood, Doshi or Lensor Radiology or Zwang Kasiri, there's always, a woman can always get a mammogram or something if she wants. The facilities are there. I think what's key though is the education, communication. A lot of people just don't know. So if we can, open up that door, that avenue, which we could just educate the patient, tell them the importance of it, I think that will definitely go a long way.
Okay, but we say that, we continuously say that, but then how do we educate them? Because we've been educating and educating and educating. So what is it that's missing? What's missing in the education part that, we keep saying it's not reaching the communities? What do you see the problem is?
Well, I think definitely more forums like what we're doing right now. Have more forums where people are involved. Where people, a lot of times, people tend to shell up or clam up, but they don't want to ask questions in different forums. But so I think as long as you have different opportunities for them to see a physician or a professional, I think that definitely helps. More outreach definitely goes a long way.
I agree. Mm-hmm.
Now, also I wanted to ask. Oh, go ahead, Vanessa.
No, go ahead. Continue.
I also had a question about fertility. Like, if you're planning on having a child, should you do the chemo and radiation, or it doesn't matter?
Well, if you want to be a mother to that child, you should be doing something, number one. And so depending on if you plan to have children, if you're a young woman who's of childbearing age, we always address with our patients the fertility option. So often, whether they've had children or they think they might be having children in the future, it's good to visit with a fertility specialist. It will not delay your treatment significantly. It won't affect your treatment significantly. But we like to get those questions answered before. Oftentimes, if there is an interest, the fertility specialist can do a cycle, which allows eggs to be retrieved and embryos to be formed and stored or frozen for after chemotherapy. So it's best to get that out on the table first, rather than waiting until you're in the middle of chemotherapy to have that conversation. Because depending on how close you are to menopause, depending on your age, chemotherapy does put you into an amenorrheic state where you're not getting your period, and it may come back afterwards, but it really does depend on how close to menopause you were before.
Now, I also want to touch on the men being diagnosed with breast cancer, because we don't talk about that too much. And I mean, it seems strange to me that men getting breast cancer. I mean, is that coming from this same thing when women get breast cancer, or is it different in men?
So men getting breast cancer is a lot less common. Oftentimes we think it's related to some kind of genetic syndrome in the family. If you have a family member who's a male who has breast cancer, that's an automatic red flag for us that there might be a genetic syndrome, and definitely genetic counseling is recommended. But outside of that, men can get breast cancer, not as commonly as women, which is why we don't do regular routine screening. But I think just with any part of your body or anything that's going on, if something is out of the ordinary, it needs to be examined by a physician or a healthcare professional. If a man feels either a lump under the breast or the nipple, if he sees discharge, these are not normal symptoms in a male, it needs to be investigated immediately. We do have a number of men that come in to be examined and to be investigated. And if we do find that there's something abnormal, we can do some of our imaging, like ultrasound and even a mammogram, which we call a manogram, to see if there's anything that's abnormal there. Men that are diagnosed at the same stage as women do just as well. The problem for men with breast cancer is that oftentimes it's not thought about, and unfortunately men will tend to present later, at a later stage, and therefore not do as well.
So Dr. Hall, do you deal with, if a man comes to your office and they're being diagnosed, do you deal with them the same way that you would deal if a woman came, that you would, follow the same, procedure with them and picking and choosing what's the best route to go?
Cancer, it doesn't really discriminate between men and women. So they are treated the same way. What I do notice though, with male breast cancer, typically I'll see women come in with stage 0, stage 1. Unfortunately, with males, they'll come with like a stage 2. Stage 2 being based on size. A lot of times, a man, they'll feel something and they'll just neglect it. They just won't follow up with it. They'll know it's a little bit bigger than their significant other, or somebody else will show concern. That's when they'll come to the office. But typically, that's why I see men coming to my office is already at stage 2. Of course, that's just based on size.
Miss Dorothy, since you have totally, truly been blessed, by God for being a survivor of 5 times. What would you say to women today about making sure that they get themselves checked? What advice would you give women today?
I would tell them to get their mammograms on a regular basis, follow the doctor's instructions, change your diet if necessary, and just hold on to your faith that all cancer is not unto death.
Now let me ask this, because we keep talking about diet, so because even if you want a strict health diet, that doesn't really keep you from getting cancer. So is this a diet after you're diagnosed, or the diet we're eating before something happens to us? Because I want to know what the difference is here that we're supposed to be eating.
I think any time that you can change your diet is important. Just because you have a diagnosis, that doesn't give you free reign to eat whatever you want either. I think as long as your body is breathing and moving, the diet is always going to help. And remember, breast cancer and cancer is not the only thing that can take our life. There's cardiac disease, there's stroke, there's diabetes. These are things that also, especially diabetes, that also can impact your risk of developing a cancer. So I think diet is always at the source of what we need to do in terms of what you actually have control of, in terms of trying to help get your body to a phase of healing and help to either withstand these treatments or to replenish your body after having had these treatments.
I agree. And I just wanted to add that since we all have predetermined cancer cells. Physical exercise just 3 times a week is very important. And I want to add something to what Doherty would recommend others who is diagnosed, is to also find out your family history. Sometimes individuals don't know if their family history, that they have a history of cardiovascular disease, any type of heart disease, stroke, cancers. They are not aware of their family history. So that's very important too. And it helps with the screening process when they go into the doctor for any elements or things that they can at least rule out.
What is the youngest age that you should start thinking about getting tested or getting a mammogram? What is the youngest you can go? I know they said 40, but I think it's like Dr. Vanessa said before, that if you got a family history, it should be tested before. So is there any particular lowest age before you start doing mammograms and testing?
So the problem with in a very young age, breasts are very dense. And as a result, with dense breasts, it's hard to really see much of anything. So we generally don't do mammograms in individuals that are in their mid to late 20s. So if you had somebody who was in their 30s when they were diagnosed, and the women in their family should be screened in their 20s, we generally will use ultrasound and or MRI at that point. The other part of mammograms is you don't want to screen somebody from their 20s because they are getting, even though it's a very, 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 very small dose of radiation, you don't want to add about basically another 10, 15 years of exposure to radiation by doing it in their 20s. So generally, if you're 30 and above, we would do a mammogram. If for some reason you had something really abnormal in your exam that made us nervous, we would do a mammogram for that. We try to minimize the surveillance or screening mammogram in the 20s. We generally will use an MRI or an ultrasound if you're a gene positive or you're in a tremendous risk.
Okay. Ms. Dorothy, after you had your second run with cancer, did you do constant follow-up with the doctor every year, or they would say you don't have to come, but every 2-3 years or something like that?
No, in 1970, when I was diagnosed with throat cancer, I had to follow up, and they did a laser in Sloan Kettering. They did a laser surgery, and I kept following up my appointments. But then in 1971, what they had did on the right vocal cord, it came back on the left. So I had to go back into Sloan Kettering, and they removed it. But I just followed up my appointments and did what I was supposed to do.
Well, Mr. Thanks to you. Thanks to God for bringing you to 5 times of surviving the cancer. So, that's hallelujah. Thank you, God. And we want to thank Dr. Manistat, Dr. Hall, for coming on and giving us some insight on breast cancer awareness, and Dr. Vanessa, we thank you, and we're praying for you as a survivor as well. And I tell you, we don't know what's going to happen to us or when it's going to come. And like you said, we just do the best we can and change our diets and doing what we have to do. And before I go, I want to wish a happy birthday to my Libra brothers in the Bed-Stuy Lions Club. Happy birthday, all you Lions in the Bed-Stuy Lions Club. So thank you for joining us today. And as always, we'll see you next time. We'll be right back with our after chat.
Thank you.
Today's show is sponsored by Abu's Bakery. If you have a sweet tooth, stop by Abu's Bakery for some delicious cakes and pies.
It's Shannon. It's Shannon. It's Shannon. It's Shannon.
Hi, we're back for our after show. I have one other question that I want to ask before you have to go. When you go for the biopsy test where they stick the needle down in your breast, now sometimes when, like they say that they see like a shadow, like a mass looking kind of shadow there or whatever, and then I was told one time it was calcium. So what causes calcium to build up in your breasts?
So the calcium deposits are actually a sign that there's some cells that are growing really quickly and dying, and your body leaves these calcium deposits. Calcium can be actually associated with both benign and malignant tissue. What drives a radiologist to biopsy one set of calcifications versus another has to do with a number of features that are associated with the calcifications. There are some benign tumors that some people may know called fibroadenomas. These get calcified, and you'll see calcium on a mammogram. These are the ones that are generally bigger calcifications, look like popcorn type images. Radiologists won't necessarily biopsy those because they look obviously benign. It's really the finer calcifications, a really small one that look like you grounded down some sand. Those are the ones that raise a little bit more suspicion because those can be associated with a very early cancer known as a non-invasive or DCIS.
Mm-hmm. Mm-hmm. So, and another question I have too is, when someone is diagnosed with the breast cancer, right, and they only do the surgery, they may have done some chemo or radiation, but then they didn't want to finish out the number of treatments that they told them to finish. So if they don't finish it out, is that a chance of there's always a chance of the cancer returning, but what happens in a case like that when, I mean, I know you don't know exactly what happens, but what do you feel may happen if they don't finish? Do you have to finish the number? If they go 12 weeks of radiation and chemo, do you have to finish it, or you can stop and not do it if you don't want to?
So generally, the regimen is created because it's what we feel has given us the best results in terms of decreasing the chance of recurrence and increasing the chance of survival. So if we'll take radiation as an example. If you only get part of the dose of radiation, the dose that was designed for radiation was to ensure that you kill all the cancer cells. So if you only take part of the dose, you may get some of the cells, but you won't get all of the cells. And the problem is, remember that cancer starts from a single cell. The same thing with chemotherapy. If the chemotherapy regimens that we find to be most effective usually involve multiple drugs. And if you don't get the entire regimen, you've killed some of the cells, but not all of the cells. The best way I always tell my patients to think about it is like taking an antibiotic. If you have a really, really bad infection or a cold, and we only give you, and we recommend 10 days of antibiotics, and you take 2, well, you may feel better for a little bit, but the infection is going to come back because you haven't killed off all the bugs.
So Dr. Hall, what does it mean? Like, okay, I had a friend, right? And she had breast cancer. So they removed lymph nodes. She said they removed lymph nodes from under her arm. And what happened was afterwards, then her arm swole up real bad. Like her arm was always constantly swollen. Her hand is constantly swollen. But she said it came because they took out too many lymph nodes. So how do they decide how many lymph nodes they have to take out?
Well, that could be true in what she's stating. I think a lot of times you'll see that when patients, it's called lymphadenopathy, lymphedema, sorry. When you see that upper extremity, a lot of times you'll see that though in older or more mature surgeons, I should say. I'm not gonna say older, but more mature surgeons. 20, 30 years ago, the whole mastectomy, that's what people used to do, just take all the lymph nodes. Our research is a lot different now. Well, it's not going to change anything. So now what we do is this lymph node biopsy. You need to just take 1 to 3, 1 to 4 of these lymph nodes, and that is it. When you limit the amount of lymph nodes you remove, you're going to decrease, of course, the chance of developing lymphedema. Lymphedema could occur from taking too many lymph nodes, like she said, or it could occur because the lymph nodes, the drainage system is blocked from the cancer itself. So those are 2 things that can really cause the lymphedema to develop, which is what your friend was going through.
So you're saying like now with all the new stuff in research, they don't really have to take out any lymph nodes?
We take them out, we biopsy them. 20, 30, 40 lymph nodes really are. All we need is a few of them to probably stage the patient. And years ago, they used to take out minimum 12, 14, 20. They used to try to take as many as possible. It didn't change anything. So that's what our research shows now. So you just need to take a few of them, in the stage 1 lymph node change to really diagnose or really stage the patient. So for patients now, nothing is 100%. So some patients may develop that, but nothing compared to 20, 30 years ago.
Oh yeah, that's interesting because although I had some lymphedema, I don't have it generally like a lot of people may have it, where they really have to go through a lot of therapy, physical therapy here, and I think we removed 3 for me, and it's just manageable. Sometimes depending on the heat, the heatness, the coldness, and what you're doing and stuff. But I have other things I had developed with my arm and stuff, my shoulder. So I just work on a lot of physical therapy at the time, just to keep the lymph, what's there, to keep anything that's there draining, to keep it constantly draining.
Well, I tell you, I'm so thankful to hear all of you, talk about the new stuff that's going on with the research and everything now, that, we don't have to be so afraid if we do get the bad news. Because let me tell you, when they sent me to get the biopsy with the needle that they stick in you, when I walked into the place, I was crying when I walked in. I cried the whole time I was there. And so when the nurse called me in and wanted to know, well, why are you crying? No one has done anything to you yet. We haven't tested you yet. No one has told you anything yet. It was just the idea that they were sending me there because they thought they saw something, which ended up being the calcium that I asked the question about earlier. And it was so scary to me. And so when they kept asking me what was the problem, why was I so scared and why was I crying and no one had told me anything, it was like I had just retired from my job. My granddaughter was just born, and I'm in there crying like, I just retired. I need to live a couple of years after my retirement. I just had a granddaughter. I need to live to see my granddaughter. I mean, I was carrying on so bad. You would have probably just thrown me out of your office if I came to your office or whatever, because it's just a shock of knowing something and you just don't know how to handle it at that time. So, I mean, it's like Dr. Vanessa said, that I guess the impact hits you, but then you got to think about, okay, now, how am I going to handle this? How am I going to get through this? How's I'm going to go through this journey, So with all the new technology now, is it's much better sounding that, you might be able to beat this.
And I just want to add, how receptive are women with support groups?
I think support groups are an individual thing. I think some people thrive in them and get support, and some people don't really like them as much as you'd think. I think a lot of that has to do with the personalities, as well as what your own village brings to the table. Some people who have large families or large supports prior to the diagnosis don't generally benefit as much from a support group. But I really think if you feel, you should at least give it a try. And if you feel that's of a benefit to you, I think the more support is always better in these situations.
Right. And I agree with Dr. Hall when he mentioned earlier how we need to get out there and get this message and get into our Black and Brown communities and our Afro communities, and let them know that these services are out there. These services are very real. We can result to faith-based with a large congregation of people, people congregate at, and it's very important. And it's just really missing. This message is really missing in our community, and it's just not really available and open. So I think, I agree that we should have as much formats as we can, and not just have it in October with this when it's Cancer Awareness Month.
Yeah. Well, I don't want to keep you all any longer. I know you're busy. And Dr. Manning said, did I hear you say you got a 9-month-old?
I
did.
Did I hear that? She's 9 months today, actually.
Oh.
What happened since the last time we seen you then?
It's been a long time.
Well, it seems like something great happened. That miracle has happened.
It did.
Congratulations to you. Congratulations to you. Yes. And Dr. Hall, thank you so much for taking the time to come on and talk to the people tonight. So we want to thank everyone for joining us again. And please, ladies, men, go get tested. Don't wait till the last minute to find out what you need. Get out, get yourself tested, so you stay ahead of the game. You don't have to act as bad as I did when they told me to go get tested. But get tested anyway then. So we want to thank everybody for joining us. And as always, we'll see you next time.
Thank you. Thank you. Bye. Wow.
It's
Today's show is sponsored by Abu's Bakery. If you have a sweet tooth, stop by Abu's Bakery for some delicious cakes and pies.
It's Shannon. It's Shannon. It's Shannon.